right, thank you for staying with the Monday Report Town Hall. We're live at the Kenyatta University Teaching, Referral and Research Hospital. We're speaking about lung cancer and Lung Cancer Awareness Month. A lot of revelations coming through and a lot of questions as well. Let's go straight into it. We'll take them in threes and then my panelists will answer as well. Start with your name, sir, and what is your question or comment?
My name is Jared. I'm a therapist in this facility. Mine is two concerns that are geared towards improving things in future. First goes to the chairman, the National Health Insurance.
Social Health Authority.
National Social Insurance.
You will clarify whether it's SHA or SHIF. Social Health Authority or Social both. Health Insurance Fund. Okay. Yes, Jared.
There is a group of population, or Kenyans in this country, who are likely to miss out on this. The people who are likely to be living with the mental illnesses and impairments, and extremely disabled people, maybe in the villages, who are heads of households. These people may not register, they will not contribute, and they are likely not to come under emergency services. How will they be taken care of? Because they are Kenyans and they need to be attended to. Second thing, the question goes to Dr. Andrew. Dr. Andrew has talked of very complicated things that I'm also struggling to understand. How will our community health volunteers, whose education levels are likely to be low, get this? Because they are our first line of defense in the community. Yeah.
Okay. Thank you. Thank you very much. Let's take the next question. Just pass the microphone. Yes, go ahead.
Okay. Thank you. My name is Frederick, and I don't know who is going to answer me this. You have talked about your machines, and me as a youth, I can see the government is allowing smoking of tobacco, and we know very well tobacco is causing lung cancer. Why does the government ban just tobacco, I mean?
Okay.
And my second question is, are there any advanced impact of lung cancer treatment, and how can they be managed to improve the life of the quality life of the patients? Thank you.
All right, let's take the final question there, then we'll, yes, go ahead.
I'm Tommy Jod from the National Taxpayers Association, running a project on tobacco tax advocacy in Africa. So just to comment in terms of tobacco cancer being an NCD, and we feel that it can be preventable. And in the strategic plan on tobacco and MOH, they cite tax as one of the key tools in terms of curbing consumption, because if you curb affordability, they won't consume. Why don't we see the ministry coming out and supporting such? Because it will be able also to gain more funds under the tobacco fund to support cessation program. The other one is, that was a comment now to Dr. Andrew. Have we had cases of children, because the data that we have currently under morbidity and mortality rates targets 35 plus. Have we had issues of 35 and below having issues of lung cancer from tobacco consumption or the novel products? Thank you.
Okay, let's start with Dr. Abdi. First from Jared, persons with mental disability in the registration, how are they taken care of?
Those are the groups, special groups that we have identified as people who will be paid for by the government as indigents, especially people with disability and mental illness. And we are working very closely with Mathare Mental Hospital as one of the places we are identifying those individuals. And we know they might not have a phone or any number, and we are trying to see how we can identify or register them with biometrics rather than the phone as the main. So yes, there are plans to onboard those vulnerable groups.
Okay. Dr. Andrew, there was a question about first, how will community health volunteers even identify this? Because it's a very complicated way of doing this, and they're the first line of defense.
So the role here for the community health volunteers is actually prevention, not detection, so prevention. Basically, of course, advising the households that they visit on cigarette smoking cessation, 2, use of cleaners of energy, and trying to minimize the use of biomass, which is charcoal, firewood, and kerosene. And where this may not be possible, then these things be actually used outdoors. So that if you're cooking with charcoal, you don't cook inside your house. Just simple advice like that, that, you know what, don't use your jiko inside the house, cook with it outside the house. Okay. Don't use your kerosene stove, just use it outside. So such simple messaging would actually go in a long way to actually make sure that Kenyans are breathing cleaner air and actually living healthier lives.
There's a question from George in terms of, have you had cases of children and people below 35 getting cancer from tobacco use?
So as we mentioned before, half the cases of lung cancer patients do not have the history of cigarette smoking. I mentioned 20 years minimum. So yes, we have cases I've had cases that I've diagnosed under the age of 35. Only one was a cigarette smoker. We did not know whether this was contributing enough, but majority of these patients who get their cancers early, those are the ones where you actually are going to think about they are probably having mutations or there's some hereditariness involved in them developing cancers like this quite early.
There was a question on advanced symptoms, is it?
Or with regards to symptomatology, people who have been on treatment may actually develop some side effects due to treatment. We actually are aware of them. And the treatment for some of these patients, unfortunately, especially the newer therapies, case in point, what we call the immune checkpoint inhibitors, they may actually cause a problem in the lung, and we may actually have to stop those treatments because sometimes for some people it could be harmful, and we have to stop. So basically the question sometimes, the challenge is then what do we do next? We'll probably try and see if there are alternatives. Where there are no alternatives, then for us doctors is first do no harm. So if my therapy is going to cause harm, I am going to withhold it. Okay. So we'd let nature to take its course rather than accelerate somebody's demise.
Okay. Grace, I'd like to hear your views from the Ministry of Health perspective. There's a question from George in terms of supporting cessation of tobacco use, and there was a more direct question, why don't you just ban the use of tobacco instead of supporting it?
Okay. Thank you for that question. I feel like it may not be as direct as we want it to be, because just like Mogoka and Mira, they're usually invested interests in certain individuals. But I believe that, yes, as a ministry, that it needs to keep the law, basically the laws that are in place, and drive towards complete cessation of having tobacco around, and even the pressure within the community. I feel if we are the ones who, we know that this is an issue in certain age groups, if there's some behavioral sort of change that is put into place, we can also be able to divert from pushing the agenda of having tobacco around. And
so it's more about competing interests then.
Yes,
there's
competing.
Revenue generation and also employment, and then there's the health of people, and then there's Dr. Andrew saying not everybody gets cancer from smoking, so...
Yeah, so it's... yeah. And yeah, so, and just to add on to something Dr. Andrew, somebody had asked about the community health promoters, if I can just add a bit, because they do quite a lot in that when it comes to TB detection and the screening. So beyond just the diagnosis, these are individuals who are a link between the community and facilities. So even after diagnosis, these are people who will follow up the patient and make sure that, yes, you've been diagnosed with probably TB or is it lung cancer? Are you following through what you've been told that you need to do? So they play quite an important role towards that bit, and also towards support, especially the psychosocial support. And yes, they also help programs to come and come up with key messages when it comes to some of the misconceptions when it comes to certain conditions, like lung cancer. Doc had talked about people talking about mtu amerogwa. Yeah. So they really do play a key role, apart from, somebody was asking, they are not that illiterate, but, they are not that literate, yes. Yeah.
Okay, let me take the next set of 3 questions. Yes, sir.
Eva, and asante sana for the good panelist. Swali yangu itaingia kwa the chairman for SHA. On 6th, last week, I registered my niece to SHA. Then tukafanya ile testing. The total amount she was supposed to pay was 500 per month, which is 6,000 per year. Nikaweka dependent. Nikifanya hii process yote, our sister alikuwa line ya admission at Othaya KNH, sababu ya mtoto yake. During the admission, aliulizwa maswali. Do you have SHA? Akasema ndio. Mtoto ndio huyo, amewekwa ICU. Amekaa ICU since tarehe 6 mpaka jana usiku, ndio alipumzika jana usiku. Leo asubuhi kuna ile process ya discharge and clearance. My cousin akaenda pale hivi kwa bills kuhesabiwa nini, akaambiwa SHA inalipa 23k, but the total bill ilikuwa 170k. Kuulizia, because ilienda to an extent akaenda kaona matron wa KNH Othaya, akaambiwa SHA inalipa 23k. Saizi, we have created our WhatsApp group as a family to try to raise the extra 100k plus. So swali yangu ni, to what limit does the SHA cater in relation to ICU, especially to a 5-year-old boy? Kwa sababu tukija hapa kwako, it seems wewe uko na more information, lakini tukienda kwa ground, mambo ni different. Thank you.
Dr. Abdi, you can answer that directly.
So when we had the Gen Z protests and the finance, the fund that we had extra, which is the Emergency Chronic Critical Illness Fund, we have set aside 35,000 per day for ICU as part of the payment, and that's why it's called Critical Illness Fund. Because of the withdrawal of the finance bill, what happened is that part of paying for critical illness now reverted back to the normal rebate, which is for a level 6, I'm assuming, which Othaya is around 4,900 per night, if not 4,500. I'm not sure the exact figure. So it depends on how many nights times the number of the 4,500. That's what it's covering. But the expectation is going forward is once now the supplementary budget is read, is to go back to the 30,000 per night for 15 nights for ICU and 10,000 for HDU. That's exactly. So the reason why we have this kind of limitations, and this is what I want Kenyans to understand, is the number of people who are registering, who are contributing. And the way an insurance works is that everyone needs to put in something, then few of us who need will get services. So if I pay 300 shilling, for example, and that translates to 3,600 a year, but I need to pay for PET scan, which is 55,000. You can see my 3,600 is impossible. to cover. So if I'm the only one who has contributed 3,600 and I need that, there's no day it will be possible. So the way this now insurance works is it's like a harambe. Everyone contributes what they can. Then this is now what we use to pay for benefits, because not all of us will fall sick. So the probability is very few of us will fall sick. Usually it's around 5% of the population are the ones who will need extreme benefits, like ICU, cancer care, dialysis, transplant. The majority of us will be fine with our usual outpatient visits. So I think that is the message. That
so the direct answer here is there's a lack of resources. It's
yes,
really that simple.
yes.
Because the idea was 35,000 per day.
Yes.
Now it's 4,500.
Yes,
because
yes.
you don't have enough resources.
There are not enough resources. And there are very few, and this is now, if more people had joined and more people are paying, the benefits can always be increased. So what we have is reviewing of those benefits and tariffs every 2 years, where people can even petition and say that this benefit is too low. Can it be increased? And it's not even under SHA. It's a separate entity that reviews these benefits and tariffs every 2 years to improve on what are the pressing needs of Kenyans.
Okay.
So that's how the law has been designed, that it's not SHA which determines what is the benefit and what's the tariff. It's an outside entity that looks at it and says the need of the population is towards this. Can we increase this benefit? Can we increase these prices?
So the government said and promised Kenyans that this issue of WhatsApp groups will be a thing of the past. Are you saying that at this particular point, we are still stuck with our WhatsApp groups?
It will be a thing of the past. That's why we have these two funds, the Chronic Critical Illness Fund, and it's just a matter of time that we will be able to provide these benefits to every Kenyan. But the reality is there are not enough resources to give everyone what they need, 100%. There will always be that small extra needs that you will have. But what should happen is in public hospitals, you shouldn't need to pay extra. For me, that is the main thing that we need to address as a government, that when you have SHA in a public hospital, you should never pay any extra shilling. Okay. It should be able to cater for your services end to end.
Okay.
Yes.
All right, yes.
Okay, this goes to Mr. Andrew and Mary. How long does one take to realize he or she is suffering from a lung cancer? And is it hereditary, or can it be passed on through genes?
Okay, next question.
So I'm Calvin. I wanted to know about the law and the act on public smoking, and how much aware are the smokers affecting indirect smokers are they as exposed as the direct smokers? Then lastly, I also wanted to raise a concern about you mentioned wood as one of the major factors that are contributing to lung cancer. So I can imagine in the rural areas. What is the distribution of lung cancer between rural and the urban areas, and what is the government actually doing in terms of engaging the people on the ground, more so in the rural areas that use charcoal as their major source of energy? Thank you.
Okay, what is your name, sir?
Calvin Odera, yes.
Okay. Let's start with the question on rural distribution of lung cancer. And
looking at most of our data, I think, has been focused on the patients who present to us in tertiary facilities, like at the Kenyatta National Hospital where I work. But lung cancer is more or less all over the country. Slight preponderance to the urban areas compared to the rural areas.
So it's more in the urban areas?
More in the urban areas. But that's from the data we have. We do not know, probably maybe the ones who are dying in the rural areas, we may not know what really killed them. Perhaps it was lung cancer. But as of now, more in the urban areas compared to the rural areas. Somebody has asked about hereditariness. We know there are certain mutations that when people develop lung cancer, we look for that actually we use for treatment. We do not know specifically which ones are hereditary at this point in time, but probably a small, very tiny number would actually be considered hereditary. There's still so much that is not known with regards to cancers.
Okay. How long does it take for one to diagnose?
So the challenges that are, as I mentioned before, by the time you have symptoms, it's late. And that's why one of the targets is to try and get the people who are at high risk. Two is we need to invest more in research and find out what is driving lung cancer in these persons who are not smokers. We just suspect that it could be indoor pollution or outdoor pollution, but exactly we do not know the answer. It could be genetics. That is actually the answer to that. So that one we do not really have an actual reason. And then, as I mentioned before, symptoms will just help us to detect early. So we cannot screen and say we'll screen these people for lung cancer. Will just help us to detect early. The question is, when you develop your symptoms, how fast do you move from the time you showed up to the first facility to the time that you're on treatment for lung cancer? So that's what myself, Dr. Helena here are working very hard to try and narrow down that time, because there are many Kenyans we lose in the process. Okay, in the process, because before you're referred from Busia, come to Kenyatta, you have to be booked for procedures. Your booking is 4 weeks down the road. Are you getting me? How can we fast track this so that people get their diagnosis early? Yeah. Are you getting me? Again, once I take the biopsy and it goes to the lab, waiting time is 2.5 weeks. How can this again be fast tracked? So there are efforts that we're trying to make to try and reduce the time from diagnosis to treatment, to keep people alive, because there are newer therapies that can actually be able to keep even people who have advanced cancer. We're not saying all is dead. There's hope for lung cancer. And we're really hopeful because we're living in the best of times. Yeah. Maybe just to say, I have a patient, she's doing 6 years with lung cancer. 6 years. Advanced, stage 4, 6 years.
And Dr. Elena, the kinds of patients who get to you, by the time they get to you, does chemo even really help? Does it work?
It works. It works. I think there's a lot of misconceptions about chemotherapy, but the truth of the matter is you have to be very careful the patients we select to be able to give chemotherapy. And for candidates that are able to receive the medication, are able to tolerate it well, we have seen improvements in terms of their functional status. So they have resolution of symptoms. The cough goes down, the shortness of breath resolves. If they had any fluid in the lungs, it goes away. When we repeat interval scans, we see some improvement. However, some cancers do come back and can be quite aggressive. And so we might have to change the line of treatment in terms of chemotherapy. But with lung cancer, and the thing about lung cancer now is that we don't just treat with chemotherapy anymore. We have to do the molecular testings because we have targeted agents that we can give. And the targeted agents work much better than chemotherapy and have fewer side effects than chemotherapy.
Okay. Grace, there was issues about laws on smoking and the impact on secondary smokers.
Okay.
Yeah. I'd like to hear a comment on that. And you can pass it around to anyone if you don't want to answer it. But go first from the MOH perspective.
There's a tobacco control unit which is established under the Ministry of Health. There are tobacco smoking laws, and then there are bylaws of Nairobi County. So for example, in Nairobi County, in the CBD, you cannot walk smoking. There are designated smoking areas. Nairobi County has also gone ahead to insist that in entertainment spots that they designate smoking areas vis-a-vis non-smoking areas. And this is a first because even if you go to certain countries that are developed, you'll not see this. People smoke everywhere. But if you smoke in the CBD in Nairobi, you'll get arrested if you're not in a designated smoking area. So those are the city council bylaws. So that's basically the county that is trying to make an initiative. There's, of course, the tobacco control laws. Challenge, as you mentioned, there's revenue this side. Some of the tobacco companies are the biggest companies we have in the country. They employ lots of people. They're paying taxes. So why shouldn't they be in business? At the same time, there's a harm bit. So there has to be a balance. So for me, one of the proposals is, can we take some of this money and use it for patients on this other side in terms of their diagnostics, treatment, oxygen therapy, and all these things that cigarettes do cause. Then somebody had mentioned about the efforts that the government has made. Keep in mind, the government banned shisha. It was banned by the former Cabinet Secretary for Health, Dr. Mailu. It has never been lifted. There's still a ban on shisha or hookah, if you're not aware. 2, there was a ban on logging and charcoal making some time back. These were efforts to actually mitigate for using charcoal. And the government went ahead to actually withdraw value-added tax for liquid petroleum gas so that more and more Kenyans would actually be able to use cleaner sources of energy. Of course, with the controversial finance bill, there was reintroduction of this. But for me, as a healthcare provider, it actually implored the government to actually reconsider value-added tax for liquid petroleum gas.
Okay.
Thank you.
Yes, you have the microphone back there. Let's take the 3 questions really quick.
Okay, thank you so much. So my name is Brian Ngesa from St. Paul's University. So, the chair for SHA has said that they have set aside. So it means in a layman's language or a Kenyan language, wametenga. So the question, the plea for the Kenyan is to accept this battle and to make this system work in every part of the country. So number 2 is about the transition from this NHIF to now this has raised.
Sorry, let's switch your microphone for a bit. We're having a bit of technical issues. There's the one behind you. Just pick the one behind you. Yes, go ahead. Yes, Brian.
Yes, so can I start?
Start your question again,
okay. Yeah. Okay, so my question is that there's this transition from NHIF to now the SHA, and majority of the people, maybe perhaps in the village, they are not in the picture about this system. So what are you doing to ensure that this message reaches to the grassroots? However, you mentioned about the efforts that you are making as far as making this information reach the community is concerned, but the Kenyans, we feel like it's not enough. So what's that extra thing that you're going to do or you are doing to ensure that this message sinks into the brains of the Kenyans? Then number 2 is to the Dr. Andrew. There's this cancer awareness demand that is now, what is the ministry or you, perhaps the KNH, you are doing to ensure that at least, because the target audience here, we are looking at maybe the university students are there also, even the high school students. So what are you doing to ensure that they get this message and also to spread out to the other people to ensure that we curb this problem? Thank you.
Okay. Pass the next question. Yes, go ahead.
Yes, thank you very much, Trevor. This is Frederick Masaki from Kenyatta University. And my question goes direct to Daktari. As explained on those people who smoke in Nairobi CBD, we do appreciate the county government of Nairobi. The other day we saw is the chief officer in charge of environment Nairobi City County taking crackdown on the Nairobi CBD. But we Kenyans and we fail to forget that we are walking in public, but we do smoke. So the crackdown has not yet been solved so far. And my question now, what policy have you put in place as the government to curb down this mess? Thank you.
Okay. Yes.
Okay.
Yes, go ahead.
My name is Dorcas Gashiri. I work in ICU here in KUTRRH. My concern is what Dr. Andrew has mentioned about the period of treatment. By the time that patient comes, that patient is referred to KUTRRH. and the time that they access the radiologicals until the treatment is started. We are at a point that we will start that treatment. That patient will come at stage 2, and by the time we are starting that treatment, we'll be in stage 4 because of the personnel issues. That patient will come, we will book that patient here in KUTRRH and give her a 3 months time to come and see an oncologist so that we start that treatment. What is the government doing? And Mr. Chair Shashi, when you were probably lobbying for this thing, did you have a sit down with the facilities that are experiencing that strain? Especially, I know that also affects KNH, it affects here, being the 2 major referrals handling the cancer patients. It is very demotivating that that patient will find me in ICU and you'll not be able to pay their bill there. We will have paid all these bills until the diagnosis. Yes, we have the diagnosis, but then we are not able to help this patient once they get our stage. When they get to stage 4 in ICU, whereby basically we are not going to do anything for that patient. It's a lung cancer. There is basically almost nothing we are going to do to restore that patient. Thank you.
Okay. Dr. Abdi, you can answer that directly. Then I'll come to the oncologist here to tell us how long it actually takes. Yeah.
So yes, we have looked at all the things that we need, and that's why one of the things that we have done, especially for the common cancers, is to do the screening. As Dr. Andrew said, lung cancer is not one of those that you can say we are screening, that you can go into the society and say, let's go and screen patients for lung cancer. But more importantly, I would say, it's just, as he said, is to work across the spectrum, from community health promoters to working very closely with the healthcare workers in the counties to increase their suspicion and pick on patients that they feel these guys need a little bit more assessment, and send and train more professionals and healthcare workers at the county level. But there was the other question, what are you doing? I think this issue of SHA, the Social Health Authority, and NHIF is one of the topics that have been discussed more and more over the last 1 year. If there is one thing that has been constant, the only challenge is everything is in the public domain. But the issue of people reading is one of the biggest challenge that we have. And it's understandable because as a society we are very oral. It is what was said, who said it. Rarely would you find someone exercising their time and mind to read a document. The reason why I say so is because if you look at the benefits and the tariffs, it's a gazetted document. It's on our website. It's everywhere. It gives the benefit and the price, clearly stipulated. You don't even need to ask the matron or anyone to tell you how much you are being paid for. It's something that you can actually even print it out and walk with it to a hospital and say, this is what I'm entitled to. But we are not saying that's enough. We have partnered with the counties. We have partnered with the CECs. We have trained the professional administration, the chiefs, the county commissioners. We have also trained the community health promoters to basically make people understand. The most unfortunate thing that we have is the disinformation. that's constantly being spread. So sometimes you hear something, then you wonder whether you are the same document or the same thing we are reading, or we live in different country, because you don't understand where people are getting some of those things. Yeah. So yes, there's a lot more we need to do, more so in vernacular radio stations and TV stations, because that's what people will understand. More to engage people in barazas at the village level, so that the message reaches rather than just expecting people to read. Okay. So there's a lot for us on our plate.
All right. Yes. Dr. Elena, is it true that it takes you 2 to 3 months to deal with a patient, and by the time they come back, they're at stage 4, if they started seeing you at stage 2?
So I hate to disagree with my colleague, but as of Friday, and I know this because I checked personally, it was a 2-week waiting time for a new patient to be seen. And what usually happens is that we sometimes do accept walk-ins when patients don't show up and a new patient walks into clinic, they're seen on the day, as I have experienced today. So we do not get patients, presenting at stage 2 and then only getting treatment when they have advanced in their disease. We have made concerted efforts to be able to map out where different professionals would be through the Respiratory Society of Kenya and the Kenya Hospices and Palliative Care Association and the Kenya Society of Hematologists and Oncologists, so that we can be able to reduce hospital-based delays. Patients present to hospital, we don't want them to be lost in the system. We want them to be able to be identified and be translated into treatment and care. We also work with our pulmonary care nurses and our hospices so that we can be able to reduce hospital admissions for patients who are towards the end and maybe in need of oxygen requirements. We can be able to safely do this at home through home-based care programs and with our community health promoters.
All right. I'll take a quick break here, but what did you say your name was again, sir? Yes, Samora. And yeah, our deepest condolences to the family that lost their child. I mean, no parent should have to bury their child. Our deepest condolences. We're taking a quick break here. When we come back, how many questions do we still have? Show of hands. Okay, 1, 2, 3. I'll take those 3 and then we wind up on this conversation. Thank you so much. We're back in just a moment.